Coming up on Mayo Clinic Q&A. Multiple myeloma is a cancer of plasma cells. These plasma cells are found in the bone marrow and are an important part of the immune system, making antibodies that recognize and attack germs. Having multiple myeloma affects these cells by producing abnormal proteins that can cause complications. Today we'll look at the treatment options of multiple myeloma and how the development of immunotherapy is helping control the disease.
We have some new agents that really help extend the amount of time that patients are able to live with multiple myeloma. And immunotherapy is really one of the major backbone of now our current treatment for multiple myeloma. The way immunotherapy works is we're trying to use the patient's own immune system, engage them or make them work stronger to fight off cancer.
Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Multiple myeloma is a cancer that forms in blood cells called plasma cells. Healthy plasma cells help the body fight infections by making antibodies that recognize and attack germs. In multiple myeloma, cancerous plasma cells accumulate in the bone marrow and crowd out the healthy blood cells. Immunotherapy, which uses the body's immune system to fight cancer, is a standard treatment option for those with multiple myeloma. March is Myeloma Awareness Month. Here with us to discuss is Mayo Clinic hematologist, Dr. Yi Lin. Welcome to the program, Yi.
Thank you. Thank you so much for having me.
Well, it's delightful to have you here today. Thanks so much for being here. Let's start with the basics for our listeners. What is multiple myeloma?
I think you explained it really well. This is exactly how I would explain it to my patients. It is a cancer of a blood cell, a subgroup of white blood cells called plasma cells. They normally live in the bone marrow. We all have them. And each plasma cell, amazingly for its whole life, it's only going to make one type of protein or immunoglobulin. And we have lots of them in the bone marrow. So they make lots of different immunoglobulins to help us fight off things like infection. And for whatever reason, we think as part of the aging process, the wear and tear on the machineries, for some patients, a group of these plasma cells that makes one type of protein are no longer dying off when they should. And they're sticking around, they're growing in the bone marrow, sometimes outside the bone marrow as well. And they're making more of that type of protein that they're making. So we call that a monoclonal or one clone, one type of immunoglobulins, a monoclonal process. And the main treatment for it is to try to kill these plasma cells or myeloma cells that are no longer dying off on their own.
So then what is immunotherapy?
So immunotherapy is literally the new kid on the block, if you will, and has a huge role in the treatment of multiple myeloma. I am probably dating myself a little bit from when I was in medical school. At that time, the treatment for multiple myeloma was pretty much chemotherapy, what we think about as traditional chemotherapy, and stem cell transplant. Those were the only options for myeloma patients at that time. And so since then, we have some new agents that really help extend the amount of time that patients are able to live with multiple myeloma. And immunotherapy is really one of the major backbone of now our current treatment for multiple myeloma. And so some of the recent ones, for example, includes immunomodulatory drugs or IMiDs. And that was started out with thalidomide. We now have kind of next generation IMiDs called lenalidomide, pomalidomide. These are all pills you can take by mouth. And they are really used along the treatment journey for the patients from the time of initial diagnosis to subsequent progression or relapse. We also have since then monoclonal antibody treatments. So these are, again, drugs that can be given IV that targets certain markers that can show up on plasma cells, sometimes not exclusively on plasma cells, but can be expressed on these plasma cells, including myeloma cells, and is trying to engage the patient's own other immune cells to help engage and fight and kill these plasma cells. So there we have daratumumab and isatuximab that targets CD38, that's just the name of the marker that's on these white blood cells. And we also have elotuzumab that targets a different marker called CS1 that can also be seen on plasma cells. And again, these drugs are often given in combination, the IMiDs, the antibodies, along with another class of drug called proteasome inhibitors. And these we consider as the main backbone of myeloma treatment.
So Yi, how do you as a hematologist decide which of the immunotherapies to use for a certain patient?
And so for these types of drugs, we really are using them from initial diagnosis and to subsequent relapse. We think there is value in using 3, even 4 drug combinations to try to induce response. Now, of course, these are conducting clinical trials, so there is some sequencing to it in terms of the likelihood of response. There is a little bit as well in terms of potential side effects and what patients are able to tolerate. And so there is a rational, somewhat, if you will, rational sequencing of these drugs. Now, in general, the way that clinical trials are being done to investigate a new treatment modality is that we want to make sure patients have gone through known treatment that we know how well it would work before we consider something more investigational. So usually a new treatment will be first approved by FDA in later lines of treatment, and then then be allowed to study in earlier and earlier lines of therapy, including upfront. One of the arguments for immunotherapy is because the way immunotherapy works is we're trying to use the patient's own immune system, engage them or make them work stronger to fight off cancer. From a biologic standpoint, these drugs may potentially work better earlier before the immune system might get too beat up by chemotherapies and other types of drugs. And so there's a lot of research about how we can try to make sure we're most efficiently testing the use of drug in the most rational settings. So in that context, we also have just in the last few years some very exciting new advances as well for treatment for multiple myeloma. We have really completely new modalities of treatment that's FDA approved. So just last year, we had the first CAR T that's FDA approved to treat multiple myeloma.
What in the world is that?
So CAR T is a chimeric antigen receptor T cell therapy, is taking, in the current FDA approved form, is taking the patient's own T cells. So there's a different type of white blood cells. Often they would be circulating in the bloodstreams already, so we can take them from the patient's blood. And we'll be taking them to a lab and genetically changing those T cells so they express a combination, we'll call chimeric, an artificial receptor that it would normally not express, that really empowers that T cell to be able to recognize better a marker that's on these plasma cells or myeloma cells, and becomes more automatically activated to kill these myeloma cells when it recognizes those receptors. So that's conceptually how CAR T cells work.
That's fascinating.
It's a little bit like science fiction. Sometimes I try to explain it like it's like, and I have a son, so I put that in context. I explain to patients, it's like RoboCops. Your T cell, their normal job is to try to kill foreign things, like infection, like cancer cells. But by the time we find myeloma cells in the body, it means that the myeloma cells have figured out ways to try to outsmart the T cells, have figured out ways to live, and the T, despite having T cells around, their own T cells aren't able to kill the myeloma cells as well. And so we're trying to, in the lab, genetically modifying, right, these T cells to be stronger and be able to recognize them better and fight them better. So it's a little bit like, super cop, super RoboCop.
Now I'm going to date myself, because what it makes me think about is Pac-Man games from my childhood. Are there some patients? Yeah, there's some patients for whom immunotherapy is not an option.
So generally, we do think, for example, the IMiDs and the monoclonal antibodies that I have talked about, we do try to use them in most settings for our patients. I think as long as they are well enough, strong enough to get some type of treatment, there will be some role to use these drugs. It's a matter of, what combination, what dosing, what frequency to balance the treatment for myeloma and the side effects. CAR T is a little different. From a patient experience, patient journey perspective, it's more complex. In some ways, it mirrors stem cell transplant, even though the technology, treatment, there are aspects that are different. But it mirrors that in the sense that CAR T is not available at all oncology, hematology practices right now because of the logistics and the specialized expertise that needed to give the treatment, to monitor and manage the side effects, particularly the immediate side effect in the first months of the cells being very active in trying to kill the myeloma cells. Those are only available as specialized treatment centers. So there are somewhere over 100 treatment centers in the US that are accredited and certified to give these treatments. So the patient have to be able to travel to those centers in order to get the treatment. The patient does need to be healthier in some aspect to be able to withstand some of the side effects, if you will, of the CAR T treatment. So there's a lot of evaluation and assessment involved to find which patient could benefit from the treatment. So there are some limitations in who might be able to get CAR T therapy.
And so if I could ask, do you do virtual consultations for patients, or do they typically come here for a consultation to be considered for therapy?
Yeah, so to know for sure if a patient can definitively go on to get the treatment, that will require an on-site to face-to-face visit, and not only with one of the myeloma specialists who are trained to give CAR T therapy, but with a number of other specialists, including neurologists, cardiologists, sometimes infectious disease doctors, to really evaluate the patient, right, as a whole person, to make sure we are comprehensively assessing all potential risks. However, during the COVID pandemic era, given we have to balance the risk of travel and potential exposures, I really think that became an opportunity for us to see how we can advance telemedicine, virtual visits, to be able to help more patients, right? And so we do offer right now initial virtual visit for patients where we're not 100% sure if that is a right fit, or there's a little bit more complexity to the patient's prior medical history, treatment history. And so that virtual visit is helpful. It's a two-way street, right? For the patients to think already ahead of time before they come to Mayo Clinic or one of the treatment centers to understand what's involved and think through how they can coordinate some of those aspects of their care. And for the providers to already have some better grasp of the patient's situation and be able to pre-schedule certain things so that when they do arrive at the treatment center, it's a more streamlined visit. So we are finding that having a virtual visit in some situations can be very helpful. to facilitate that. And occasionally it may be the virtual visit. We may identify the patient may not be the best candidate for the treatment, save them a visit and offer some recommendations for treatment that they can get at home.
Thinking about immunotherapies, Yi, what is Mayo Clinic's approach to the use of these therapies in treating multiple myeloma?
So this is a very fast-moving field, right? And what we're always trying to strive toward is, can we find a cure? Can we confidently say a cure? And in myeloma, it's been challenging. I think we have treatments that are demonstrating longer and longer periods of remission where we can't find multiple myeloma by the available clinical test in their bone marrow, in the blood, in the body, by scan, which is great. But we're still a little bit like, well, this may still come back and we need to watch, we need to see, what additional treatment we may have. And what we always want to strive towards is the treatment that we think can offer the longest period of remission, but balancing that with side effects that can be reversible, can be manageable, because we want to keep the patients not only living as long as they can with multiple myeloma, hopefully with a lot of this being myeloma-free period, but also it's important is quality of life, right? If right now we don't have a treatment where we can guarantee that the myeloma would never come back, we want to make sure that the time they have are the time that they can do what they want with their life, the activity that are important to them. And so it's recognizing the potential side effect. It's very, very key to part of that. Now, we are also a CAR T treatment center. We are a transplant center. And so, I personally do believe in the powers of these technologies. And I think we're just beginning to see what CAR T can do. There's a lot of clinical trials, innovations in research, and to try to advance this technology. And so whenever a patient that we think is fit enough to potentially get CAR T, it is something that we would preferentially consider, because this is the only treatment right now that we have in multiple myeloma that is, the way that is approved by FDA, is a one-time treatment. We give them the cells as a one-time infusion, and if they are in response, we give no other treatment, we just monitor. There is no maintenance therapy, there's no other drug that's given as long as they are in response from CAR T. Everything else that I just talked about, whether it's chemotherapy, the IMiDs, the antibodies, those are given continuously in some fashion until the patients progress. And so I have personally heard from patients who did respond to CAR T treatment tell me this is the best they felt. They're now remembering what it's like before they were diagnosed with myeloma. And so that quality of life, right, is not trivial. Sometimes the patients get nervous because, CAR T right now is offered as in the relapse setting after they've already had at least 4 lines of treatment. So up until then, they were used to, okay, every week I may need to come into a chemotherapy unit. Every month I need to see my doctor. And once we tell them, you're good, we'll see you in 3 months just for testing, there's no treatment we're giving you, they're a little bit like, oh my gosh, what would I do, right, with my time? I can go to my lake cabin, and that's a great thing to see, and that's not trivial, I think, in terms of the benefit that this treatment could offer.
That is very exciting. I'm wondering, is Mayo Clinic conducting clinical trials of immunotherapies and multiple myeloma and other research that's non-clinical?
Absolutely. We really do believe clinical trial is what's needed to advance, right, the treatment options we have for our patients. So in addition to the FDA approved treatment that needs to be given at specialized centers that we offer, we do have clinical trials with in CAR T, in bispecific antibody, which I'll touch on next as the next new treatment modality that we are very excited awaiting FDA review later this year. But also, with now there's kind of new generations of antibody therapies, novel combination therapies, targeted therapies. We do think, and oftentimes, once the patients have gone through these approved treatment, it's the clinical trials are, what may potentially offer them additional response, right? Additional time that they may have with their family and loved ones. So we are definitely very excited to be able to offer a lot of these novel clinical trials to our patients. And so what I was alluding to next was there is another new class of treatment that we've been offering clinical trials to our patients, and we're anticipating the first drug of this kind will be reviewed by FDA for potentially as an approved treatment later this year, and that's called bispecific antibody. So what I mentioned earlier, we have the monoclonal antibody, the daratumumab, isatuximab, elotuzumab. Those are an antibody that just target one marker. And the bispecific, too, it's exactly as the name implies, is targeting two markers. So one of the marker it targets would be a marker that's on a myeloma cell. And then the other target is on a T cell. That's the most common one that's being studied. There are tri-specific, so 3 targets in clinical trial testing that try to engage T cells, sometimes T cells and NK cells. So these are all white blood cells that can potentially kill, right, myeloma cells. And so CAR T is, we try to take the patient's own T cells out of their body, do the genetic engineering to make the T cells work stronger, and then put it back in the patient. You can imagine that manufacturing time, that genetic modification time, that on average takes about a month. And so not all patients can wait a month to get their own genetically engineered T cells back, right? And so the bispecific antibody is, again, it's an off-the-shelf drug. So it's trying to say, hey, maybe in some patients, their T cells are going to work well enough without having to do the genetic engineering. Can we simply use this drug to bring a T cell, the patient's own T cells that's already in their body? We're not doing any fancy genetic engineering. We're just trying to bring the T cell closer to the myeloma cells with this bispecific antibody. So it is still more like all the other drugs we have for myeloma. It can be given IV or as an injection under the skin. There's been a lot of technology advances to enable us to give it once a week or once every 2 weeks or once every 3 weeks, depending on which drug that's in testing. It does need to be given kind of continuously until it stops working. But the advantage to that is, there's no wait time for the patients. There's also no need to give some chemotherapy to prepare the patients to receive the cells. And so for some patients, that may be a very good choice. And we are seeing some very exciting clinical responses in clinical trials. So, I think this may be an approved treatment in the very close future for our patients as well.
What fascinating information. Thank you for being here to share this, Yi.
No, absolutely. Very excited to just even in my time, right? And I don't have as many gray hairs as many of my colleagues in our group, but just to see even in my time on staff at Mayo that we have so many new options for our patients, and very, very honored to be part of the myeloma group to continue to do these clinical trials and hopefully offer even more treatments for our patients in the future.
And we are so grateful for the work that you are doing.
Thank you so much.
Our thanks to Dr. Yi Lin, hematologist at Mayo Clinic, for being here with us to discuss therapies for multiple myeloma. March is Myeloma Awareness Month, and I hope that you learned something today. I know that I did. We wish you each a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.